Welcome to Pediatric Case Review. Today we present a comprehensive lecture on Noonan Syndrome, designed for pediatricians and clinicians. This interactive presentation uses case-based questions to enhance your clinical knowledge and diagnostic skills in recognizing and managing this important genetic condition. Question 1. A 3-year-old boy presents with developmental delay and dysmorphic features. Which facial feature is most characteristic of Noonan Syndrome? Option A. Epicanthal folds and downslanting eyes. Option B. Micrognathia and cleft palate. Option C. Downslanting palpebral fissures and low-set ears. Option D. Broad nasal bridge and thin upper lip. The correct answer is C. Downslanting palpebral fissures and low-set posteriorly rotated ears are hallmark facial features of Noonan Syndrome. Additional characteristic features include hypertelorism, ptosis, and a high-arched palate. Remember that facial features become more subtle with age, making early recognition crucial for timely diagnosis and management. Question 2. A newborn presents with a heart murmur and characteristic facial features suggestive of Noonan Syndrome. What is the most common cardiac defect associated with this condition? Option A. Atrial septal defect. Option B. Pulmonary stenosis. Option C. Aortic stenosis. Option D. Tetralogy of Fallot. The correct answer is B. Pulmonary stenosis is the most common cardiac defect, occurring in 50 to 60% of patients with Noonan Syndrome. Hypertrophic cardiomyopathy affects 20 to 30%. Other defects like atrial septal defects are less frequent. All patients with suspected or confirmed Noonan Syndrome should undergo echocardiography for cardiac screening. Question 3. A 5-year-old girl with Noonan Syndrome has height measurements below the 3rd percentile. What is the expected growth pattern in Noonan Syndrome? Option A. Normal birth length with accelerated growth after puberty. Option B. Short stature at birth with catch-up growth by age 2. Option C. Normal birth length with progressive growth delay. Option D. Tall stature with delayed bone age. The correct answer is C. Children with Noonan Syndrome typically have normal birth length but develop progressive postnatal growth delay. Mean adult height is approximately 151 centimeters in females and 162 centimeters in males. Growth hormone therapy may improve final height. Use Noonan-specific growth charts for accurate monitoring. Question 4. During routine examination of an 8-year-old boy with Noonan Syndrome, you assess his chest wall. What is the most common chest wall deformity seen in this condition? Option A. Pectus excavatum. Option B. Pectus carinatum superiorly with pectus excavatum inferiorly. Option C. Barrel chest. Option D. Straight thoracic spine. The correct answer is B. The characteristic chest deformity combines pectus carinatum superiorly with pectus excavatum inferiorly, creating a shield-like appearance with widely spaced nipples. This occurs in 70 to 95% of patients. The broad chest with this unique configuration is highly suggestive of Noonan Syndrome and may require surgical correction in severe cases. Question 5. A 10-year-old child with Noonan Syndrome presents with excessive bruising and prolonged bleeding after dental extraction. What is the most common coagulation abnormality in Noonan Syndrome? Option A. Hemophilia A. Option B. Von Willebrand disease. Option C. Factor XI deficiency and platelet dysfunction. Option D. Thrombocytopenia. The correct answer is C. Factor XI deficiency is the most common coagulation abnormality, affecting 55% of patients. Platelet dysfunction and thrombocytopenia are also frequently observed. Von Willebrand disease occurs in 10 to 20%. Always perform comprehensive coagulation screening before any surgical or dental procedures in patients with Noonan Syndrome. Question 6. A newborn with Noonan Syndrome presents with puffy hands and feet. What is a characteristic lymphatic manifestation in infancy? Option A. Chylothorax only. Option B. Lymphedema of hands and feet. Option C. Intestinal lymphangiectasia. Option D. Persistent lymphadenopathy. The correct answer is B. Congenital lymphedema affecting the hands, feet, and nuchal area is characteristic of Noonan Syndrome in infancy. This typically resolves during early childhood. Posterior cervical hygroma may also be present. Neonatal chylothorax can occur and requires appropriate management. These lymphatic abnormalities reflect the underlying dysplasia of the lymphatic system. Question 7. Parents of a child diagnosed with Noonan Syndrome seek genetic counseling. Which cellular signaling pathway is primarily affected in Noonan Syndrome? Option A. Tumor necrosis factor pathway. Option B. RSMPK signaling pathway. Option C. WNT signaling pathway. Option D. Notch signaling pathway. The correct answer is B. Noonan syndrome results from mutations affecting the RAS-MAPK signaling pathway, classifying it as a RASopathy. The PTPN11 gene accounts for approximately 50% of cases. Other genes include SOS1, RAF1, and RIT1. Inheritance is autosomal dominant with variable expressivity. Understanding this pathway explains the multi-system involvement characteristic of the syndrome. Question 8. An infant with Noonan syndrome has a dysplastic pulmonary valve on echocardiography. How does RAS-MAPK pathway dysregulation lead to cardiac defects? Option A. Direct cardiac muscle toxicity. Option B. Abnormal cell proliferation during cardiac development. Option C. Immune-mediated valve destruction. Option D. Mitochondrial dysfunction. The correct answer is B. The RAS-MAPK pathway regulates cell proliferation and differentiation during embryonic development. Dysregulation affects cardiac septation and valve formation, resulting in structural defects like dysplastic pulmonary valves and septal defects. Abnormal myocyte proliferation can lead to hypertrophic cardiomyopathy. This explains the high prevalence of cardiac abnormalities in Noonan syndrome. Question 9. You evaluate a child with suspected Noonan syndrome using clinical diagnostic criteria. How many major criteria are typically required to establish a clinical diagnosis? Option A. 1 major criterion. Option B. 2 major criteria. Option C. 3 major criteria. Option D. All major criteria must be present. The diagnosis uses the Vanderburg scoring system with major and minor criteria. Major criteria include characteristic facial features, congenital heart defects, and positive family history. Minor criteria include developmental delay, cryptorchidism, and lymphatic dysplasia. Typically 2 to 3 major criteria or multiple combinations establish clinical diagnosis. Genetic testing provides definitive confirmation. Question 10. A 4-year-old child has clinical features suggestive of Noonan syndrome, but the diagnosis is uncertain. What is the most appropriate initial genetic testing approach? Option A. Karyotype analysis. Option B. Single gene sequencing for PTPN11. Option C. Multi-gene RASopathy panel. Option D. Whole exome sequencing. The correct answer is C. A multi-gene RASopathy panel is the most appropriate initial test, as it simultaneously analyzes multiple causative genes, including PTPN11, SOS1, RAF1, and RIT1. This approach is cost-effective and detects 80 to 90% of cases. However, remember that negative genetic testing does not exclude the diagnosis, as clinical criteria remain important. Question 11. A 6-month-old child is newly diagnosed with Noonan syndrome. The initial echocardiogram is normal. What is the recommended follow-up echocardiography schedule? Option A. No further screening needed. Option B. Every 5 years. Option C. Annually until adolescence, then every 5 years. Option D. Only if symptoms develop. The correct answer is C. Annual echocardiography is recommended throughout childhood and adolescence, as hypertrophic cardiomyopathy can develop later even with normal initial screening. After skeletal maturity, screening can extend to every 5 years. Annual electrocardiograms are also recommended. This surveillance ensures early detection and management of cardiac complications. Question 12. A 3-year-old child with Noonan syndrome presents with speech delay. What is the expected cognitive and developmental profile? Option A. Normal intelligence in all cases. Option B. Severe intellectual disability. Option C. Mild learning difficulties with normal to low normal intelligence. Option D. Progressive cognitive decline. The correct answer is C. Most individuals with Noonan syndrome have normal to low normal intelligence with IQ scores between 70 and 100. Speech and language delays are common, as are motor milestone delays in infancy. Learning disabilities occur in 25 to 65%. Early developmental assessment and intervention significantly improve outcomes. Question 13. A 7-year-old with Noonan syndrome has height at the 3rd percentile with declining growth velocity. When is growth hormone therapy approved for use? Option A. Never approved for Noonan syndrome. Option B. Only with documented growth hormone deficiency. Option C. Approved for short stature in Noonan syndrome. Option D. Only after puberty. The correct answer is C. Growth hormone therapy is FDA approved for treating short stature in Noonan syndrome, even without growth hormone deficiency. It improves growth velocity and final adult height. Cardiac evaluation is essential before initiation, as growth hormone may worsen hypertrophic cardiomyopathy. Regular monitoring during treatment is crucial at doses of 33 to 66 micrograms per kilogram per day. Question 14. A 1-year-old male with Noonan syndrome has bilateral undescended testes. What is the recommended timing for orchiopexy? Option A, immediate surgery in infancy. Option B, between 6 and 18 months. Option C, wait until age 5 years. Option D, surgery is not necessary. The correct answer is B. Cryptorchidism affects 60 to 77% of males with Noonan syndrome. Orchiopexy is recommended between 6 and 18 months of age to optimize fertility potential and reduce testicular cancer risk. Earlier surgical intervention yields better outcomes than delayed surgery. Hormone therapy is rarely effective in this population. Question 15. Parents of a child with Noonan syndrome ask about cancer risk. What type of malignancy shows the strongest association with Noonan syndrome? Option A, brain tumors. Option B, leukemia and myeloproliferative disorders. Option C, renal tumors. Option D, no increased cancer risk. The correct answer is B. Children with Noonan syndrome have increased risk of leukemia and myeloproliferative disorders, particularly juvenile myelomonocytic leukemia. Acute lymphoblastic leukemia risk is also elevated. Children with peak PN11 mutations face highest risk. Regular complete blood count monitoring is recommended. However, absolute risk remains relatively low and routine surveillance is generally sufficient. Question 16. A 3-month-old infant with Noonan syndrome has poor weight gain and feeding difficulties. What is the most appropriate initial intervention? Option A, immediate gastrostomy tube placement. Option B, multidisciplinary feeding evaluation and thicken feeds. Option C, change to specialized formula only. Option D, withhold feeding until swallow study. The correct answer is B. Feeding difficulties affect approximately 70% of infants with Noonan syndrome. A multidisciplinary evaluation including pediatrician, dietitian, and speech therapist is essential. Thicken feeds may benefit those with dysphagia. Gastrostomy tube placement is reserved for severe cases unresponsive to conservative measures. Most feeding issues improve significantly by age 2 years. Thank you for joining this comprehensive lecture on Noonan syndrome. Remember the key clinical features: distinctive facial characteristics, cardiac defects, particularly pulmonary stenosis, short stature, and bleeding diathesis. Early recognition and multidisciplinary management are essential for optimal outcomes. Please subscribe to Pediatric Case Review channel for more informative presentations. If you have questions or clinical cases to discuss, leave them in the comments below. Thank you for watching.